everyone. Thanks for joining us for this discussion on navigating the nutrition assessment of transgender and gender expansive patients. I'm Dr. Jennifer Waters, and I use she and her pronouns. My primary research area focuses on the health and nutritional care of the transgender and gender diverse patient population. Also joining me today is Dr. Whitney Linsenmeyer, who will be starting us off.
Hi, everyone. My name is Whitney Linsenmeyer. I also use she, her pronouns, and my research centers on gender-affirming nutrition care for the gender-expansive population. And I'm especially interested in how we can train future RDNs, our students, to provide excellent care for their future transgender patients and clients. I'm starting us off today with some brief best practices on gender-affirming communication. And I always say that this is the most important thing to get right with our patients. It's more important than if we correctly calculate those energy needs, because if we don't get this piece right, we're going to miss that critical opportunity to build rapport with our patients. And we know that many of our transgender clients have had really negative experiences in healthcare and at the hands of healthcare providers. So our communication is key to building and maintaining our patients' trust. So first, with name and pronouns, I'm sure you've heard this before, but we want to make sure that we are using every patient's name and pronouns correctly. And one of the simplest ways that we can do this is just by having this be routine data that we collect on our patient data collection form, our intake forms. Patients may need to include their legal name for insurance purposes, but we can also always have a spot for preferred name or chosen name, and then a spot for pronouns. We can also share our own name and pronouns on a variety of different ways by introducing ourselves verbally. We can put it on our hospital badges or on our Zoom name if we're doing telehealth. And we know that mistakes do happen, so we can just be prepared for what to do when those instances arise. We can briefly acknowledge the mistake, apologize briefly, and then move right along so we don't overly dwell on it. And then next, with gender neutral language, we can be attuned to some of those very gendered language that we hear sometimes in healthcare and maybe don't even think about. Things like the mother baby unit of a hospital or mommy and me time. And we can just be comfortable using more gender neutral terms, things like the birthing parent or the chest area instead of breasts. Next, we have a lot of research showing that transgender patients are often asked very inappropriate questions, things about their genitals or their history of gender-affirming surgeries, for example, when getting something entirely unrelated like a COVID test. So we can ensure that our questions are relevant to the care that we as RDNs are providing, and perhaps if needed, to even get a little bit of context to help our patients to understand why we're asking the questions that we are. So for example, we could say something like, different types of medicines can impact your lipid levels, which are also impacted by your diet. So I'd like to ask you about any medicines that you are taking, including hormone therapy, so that I can better understand everything that may be impacting your cholesterol levels. And our last piece for gender-affirming communication is on physical touch. And gang, physical touch is a big one. We know that many of our transgender clients have experienced inappropriate physical touch at the hands of healthcare providers, and even physical abuse. So a trauma-informed approach is especially important here, but there's more to talk about than we even have time for in this video today. So you can watch our other DNS video on the NFPE here, which goes much more in depth into considerations for physical touch. Next, I'm going to touch briefly on the gender-affirming medical and surgical treatments that transgender patients may undergo. And it's important to note that not all trans patients will be on hormone therapy or have undergone surgeries. Everyone's transitioning journey is different, and that's why we need a thorough medical and surgical history to understand the unique patient in front of us. So first, hormone therapy involves taking testosterone or estrogen and or anti-androgens that are designed to induce secondary sex characteristics associated with males or females. For example, testosterone induces an increase in muscle mass and strength, a deepening of the voice, and facial hair growth, whereas estrogen induces breast growth, softening of the skin, and decreased oiliness, and an increase in fat mass. For youth, treatment involves taking puberty blockers beginning at Tanner stage 2, which are designed to delay the onset of puberty for a period of time. We can think of this as like a pause button on puberty until the patient can then begin masculinizing or feminizing hormone therapy, or can go off of the medicine, go off of those puberty blockers, and then allow puberty to continue. Different types of gender-affirming surgeries are also an option for patients and can include gender-affirming top surgeries to the chest region. This can include things like a breast augmentation or mastectomy, bottom surgeries to the genital and reproductive region, things like a hysterectomy, vocal cord surgeries, and facial surgeries. And just a brief note on access to hormone therapy and gender-affirming surgeries is becoming increasingly complicated and really looks different from state to state, as well as what the patient's insurance may cover if they have medical insurance. So it can be helpful to familiarize yourself with access issues in your state where you are practicing.
As part of conducting a thorough nutrition assessment, dietitians are accustomed to reviewing the patient's inpatient medication orders and their list of home medications. As you probably know, we do this to evaluate for any medication-nutrient interactions, to explain any biochemical changes or gastrointestinal side effects that the patient may experience, to anticipate any nutrition-relevant changes that might present after long-term use of the medication, and it also just helps us better understand the patient's overall clinical picture and treatment plan. As Whitney mentioned, folks who decide to transition through the use of hormone therapy will be prescribed certain medications. I'm going to spend just a few minutes talking about the medications in a bit more detail so dietitians know what to look for when reviewing the patient's medical record. The information that I'm going to present is from the World Professional Association for Transgender Health, or WPATH. For adults who pursue masculinizing hormone therapy regimens, it will include testosterone. Testosterone can be provided as an injection administered either intramuscularly or subcutaneously, which is provided at various intervals or in the form of a transdermal patch or gel that gets applied on the skin daily. Some of the specific medication names might include testosterone enanthate, testosterone sapionate, or testosterone undecanoate. For a feminizing hormone therapy regimen for adults, the patient will be prescribed estrogen. The form of estrogen used most commonly is 17-beta estradiol, or more simply referred to as estradiol. Estrogen-based hormone therapy can be provided in a number of different ways and under the more specific names of estradiol valerate or estradiol sapionate, just to name a few. It can be provided as an oral or sublingual tablet. Estradiol can also be administered through the use of a transdermal patch or gel, which is applied to the skin daily. Additionally, there is the option of an injectable estrogen. This is administered intramuscularly every week or every couple of weeks. Transgender women or transfeminine individuals who have not pursued an orchiectomy, which is the surgical removal of the testicles, will also require a class of medication referred to as an anti-androgen. Spironolactone is commonly used as an anti-androgen. This is a drug that dietitians are generally familiar with, as it is also used as a potassium-sparing diuretic. Another anti-androgen that may be prescribed, though less commonly in the US, is cyproterine acetate. These anti-androgen medications bind to androgen receptors in the body, thus blocking the body's ability to use its endogenous testosterone. It is important to note that the medications and hormones that I've discussed are not exclusive to gender-affirming treatment, but are also used for a wide variety of conditions. And so seeing some of these on the medication list, it should not be automatically assumed that they're being used for the purpose of medical transition. When a patient is on a gender-affirming hormone therapy regimen, they are monitored very closely for physical changes and for their hormone levels to be within a therapeutic range to align with their gender identity. Medication doses vary and are adjusted by the provider as needed. The WPATH standards of care provide more specific dosing ranges that you can refer to if you're interested. Medically transitioning through the use of hormone therapy is generally effective and well tolerated. Like any medication, though, hormone therapy can have side effects and impact certain health-related measures. These changes really underscore the importance of critically evaluating lab values, as traditional male and female reference ranges might not accurately reflect the physiological changes occurring during hormone therapy. Understanding how hormone therapy influences biochemical markers is essential for accurate assessment and effective nutrition care planning. As far as the impact of hormone therapy on cardiovascular health, masculinizing therapy is often associated with increases in total cholesterol, LDL cholesterol, triglycerides, and reductions in HDL. These trends may elevate cardiovascular risk and highlight the need for early dietary intervention. Feminizing therapy shows much more variability. Some studies report favorable reductions in LDL and triglycerides, while others find increases or no change. Outcomes are certainly influenced by type, dosage, and route of hormone administration. As for the impact on hematologic measures, testosterone's erythropoietic effect commonly leads to higher hemoglobin, hematocrit, and red blood cell count in individuals on masculinizing regimens. Estrogen-based therapy tends to lower these markers. Reference ranges should reflect an individual's current hormone exposure and stage of treatment to ensure accurate interpretation of values like hemoglobin and hematocrit. While there is less research on the impact of hormone therapy on hepatic and renal labs, let's talk about what we do know as of now. Changes in liver enzymes like ALT, AST, alkaline phosphatase, and kidney markers like creatinine are inconsistent across the studies. However, creatinine typically rises with testosterone due to increases in lean body mass and falls with estrogen due to decreases in muscle mass. Potassium levels may increase with the use of spironolactone, which, as we previously discussed, is a common anti-androgen used in feminizing therapy. And this highlights the need for regular monitoring of electrolytes. The impact of hormone therapy on fasting glucose, A1C levels, and insulin remains inconclusive. Some studies report mild increases, others show no change. At this time, these findings are not sufficient to support any routine changes to clinical decision-making, but do highlight an area for ongoing monitoring. Because many of these markers are responsive to nutrition interventions, recognizing the potential impact of hormone therapy and monitoring these values more closely allows nutrition professionals to anticipate changes and intervene earlier with targeted nutrition strategies. For a more detailed breakdown of these findings, you can refer to the full article published in Frontiers in Nutrition linked in the materials. So now I'm going to discuss some of the challenges associated with sex-specific measures. One of the complexities in assessing transgender patients is that many aspects of our assessment process depend on binary sex categories. We see this in predictive equations, biochemical reference ranges, and nutrient recommendations. This becomes especially challenging when working with transgender and gender diverse clients, particularly those undergoing or considering medical transition. A question that often comes up is, how should I approach determining energy needs for a transgender patient or client? It's a reasonable question, as many energy equations require a sex designation. But this issue isn't limited to calorie calculations. It cuts across several areas of the nutrition care process. Let's talk about where sex-based distinctions do come into play during a nutrition assessment. So equations like Mifflin-St. Jeor that we use often require us to plug in a different set of calculations for males and females. The same goes for DRI-based recommendations, many of which are divided into male and female categories. While some nutrients like vitamin D have similar RDAs across sexes, others show significant variation. Iron is a really good example. Menstruating individuals have nearly double the RDA compared to those who don't. Interpretations of body fat percentages, waist measurements, and waist to hip ratios depend on sex-specific cutoffs. Growth charts for children and teens also differ by sex, affecting BMI for age percentiles. Many of the biochemical reference values are often sex-based. These include components of the lipid panel, red blood cell indices like hemoglobin and hematocrit, renal function markers like creatinine, and liver enzymes such as alkaline phosphatase. Bone density scores are also interpreted in relation to sex and age-matched norms. So to address these challenges, we do have a few evidence-informed strategies for nutrition professionals. First strategy, for clients who have not started hormone therapy or are early on in their medical transition, perhaps less than 6 months, use reference ranges that are aligned with sex assigned at birth. Now, this approach generally reflects their current physiology and provides the most accurate interpretation of lab values in anthropometrics. For clients undergoing hormone therapy, consider where they are in their medical transition. Physical changes like shifts in lean mass, fat distribution, or hematologic values occur over time and do vary by individual. The Endocrine Society guidelines, which are linked in the resources, outline typical timelines for these changes, which can help inform decisions about when to shift from one set of reference values to another. A 6-month threshold is often used as a general guide for when to shift toward reference values that align with the physiological changes expected from hormone therapy. But again, all patients are not the same, and clinical judgment here is imperative. When appropriate, use a hybrid or range-based approach. For certain assessments, particularly where ranges are already common, like in determining energy needs, it may be useful to present data using both male and female reference points. This can be especially relevant early on in transition or when patients or clients are on moderate or non-binary regimens. There's no single correct method that applies in every case. Patients are never one size fits all. These decisions require thoughtful clinical judgment, collaboration with the broader care team, and open communication with the patient or client. Adapting your approach based on where they are medically and physiologically can support both accuracy and affirming care. We're going to apply this information with an inpatient case study. Jordan is a 26-year-old admitted to the hospital with diabetic ketoacidosis and a new diagnosis of type 2 diabetes. He's now more stable than when he was admitted yesterday. He was assigned female at birth, identifies as a trans man, and uses he and him pronouns. He has been receiving intramuscular testosterone injections weekly for the past 18 months. Jordan is 5'6" tall and weighs 210 pounds. He reports several days of fatigue, poor appetite, and increased thirst and urination. He has a history of hypertension managed with lisinopril. He has not previously received nutrition counseling or diabetes education. His abnormal labs include a hemoglobin A1C of 10.3%, a creatinine of 1.4 milligrams per deciliter, and a hemoglobin of 16.6 grams per deciliter. In this case, we need to consider sex-specific factors that influence both Jordan's lab interpretation and energy needs. One key question is, how do we approach estimating energy requirements for a transgender patient during hospitalization? Jordan has been on testosterone for over a year, which likely has increased his lean body mass and altered his metabolic rate. Using the male version of a predictive equation like the Mifflin-St. Jeor is appropriate given these physiological changes. If there's uncertainty about body composition, a range between male and female estimates can certainly be used, adjusting based on clinical status. And taking a closer look at his lab values. Hemoglobin is elevated compared to female reference ranges, but appropriate for a patient on testosterone. We would interpret using the male norms here. Creatinine is also consistent with expected increases in lean body mass. It should not be misinterpreted as a renal impairment without additional signs and evidence to support that assumption. His elevated A1C confirms significant hyperglycemia and the need for nutrition intervention. Note that A1C is not sex-specific, so no adjustment in interpretation here is needed. And now I'm going to turn it back to Whitney, who's going to walk us through an outpatient case and share a few resources for those interested in exploring this topic further.
Next, I'll share a brief case study of a patient, Leon. Leon is a 17-year-old, not Hispanic, white patient who was referred to see an RDN for disordered eating. Leon was assigned male at birth, identifies as non-binary, and uses they, them, and she, her pronouns. They are not currently on hormone therapy or puberty blockers, and they are not currently interested in pursuing hormone therapy or gender-affirming surgeries in the future. Leon is 66 inches tall and weighs 54.5 kilograms. Which growth chart would be most accurate to assess Leon's weight status? So growth charts, that's another one of those areas that we know are sex specific, right? We have the growth chart for boys or girls. So given that Leon has not medically transitioned, using the growth chart consistent with their sex assigned at birth, male, would provide the most accurate assessment. And I know this can give people pause sometimes, feeling like they're not honoring the patient's gender identity by using a value consistent with their sex and not with their gender. But it's important that we can, yes, honor the patient's gender identity in very important ways, things like using the correct name or pronouns like we talked about earlier, while still providing the most accurate nutrition assessment possible. So next, we have a few helpful resources to share before we go. In terms of clinical practice guidelines, we recommend familiarizing yourself with the WPATH Standards of Care version 8 and the University of California, San Francisco Standards of Care. The latter are really geared more towards primary care, but I find them very helpful in understanding what patients can expect, especially when undergoing gender-affirming care. They also have a good section on physical touch and a physical exam. And then other resources linked here include a scoping review on transgender health and nutrition. This was published by the Academy of Nutrition and Dietetics and is available in the evidence analysis library. Also handouts that are published in the nutrition care manual for use with your trans clients. This is in the adult NCM. An overview article on nutrition considerations that is published in JAN. This is really just broadly looking at what are those nutrition related considerations from a clinical and psychosocial perspective. And then lastly, this is the article that Jen first authored and referenced that is published in Frontiers in Nutrition, which is on hormone therapy and nutrition biochemical measures. If you are interested in reading more about this topic, we have an article that is published in the Journal of the Academy of Nutrition and Dietetics. So check out the link in the video description here. Thanks so much for joining us, and we'll see you next time.